Welcome to another episode of the Wealthy Podcast. I'm your host, Shauna Nairos, and today's episode is all about pain. It is a condition that every single one of us has experienced at some point in our lives. And our guest today is Vince Cunanan, one of the best people to talk about pain because he is a physiotherapist. He's the clinic director at Sun City Physiotherapy, and he is the president of the Physiotherapy Association of BC. And Vince is really great at deconstructing all the different types of pain and all of the ways that physiotherapy can help us navigate our pain stories. He's a specialist in TMJ, which is a condition that many people struggle with, but he's also extremely good at really breaking down how we can use physiotherapy and different practices to support our lives. You're going to want to listen up. Today's episode is for anyone who's ever felt tension in their neck that just won't quit. For anyone who's lived with persistent headaches, jaw pain, stiffness, brain fog, or that gnawing sense that something in your body just doesn't feel right, which is pretty much all of us at some point. Mm-hmm. Maybe you've chalked it up to stress, aging, sleeping funny, or maybe you've just learned to live with it. But what if your body is trying to tell you something and we just haven't been listening in the right way? To help us tune in a little deeper, I'm joined by Vince Cunanan, a registered physiotherapist, clinical director at Sun City Physiotherapy, and the president of the Physiotherapy Association of BC. Vince specializes in treating complex conditions like TMJ, which I am all ears for this one, oral facial pain, neck dysfunction, and more. But what really drew me in was how Vince talks about pain as information, as relationship, as opportunity. What is pain? How does it show up in the body? And how do we know when it's acute, chronic, mechanical, or even emotional? What is physiotherapy really about and who is it for? Spoiler alert, it's not just for people recovering from a sports injury. It's for people recovering from life. So let's start there. Welcome, Vince.
Thank you. Thanks for having me. I'm grateful.
I'm grateful too. Yeah. It's really, really nice to have you. Well, we have a bit of an opening tradition on the podcast. I am curious, as you sit here today, looking back over your life and maybe young Vince, what drew you to health or healthcare? What maybe inspired you, or did you have an early experience that really informed your path?
Yeah, when I'm asked this question, there's sort of two parts to it. Number one, as a child, I always knew that I wanted to be in healthcare, helping people in some capacity. My dad was actually a dentist in the Philippines. And when we immigrated to Canada, it was, new family, no money. So he couldn't actually kind of pursue dentistry because he had to go through all of these hoops. So I knew that going through high school, it would either be some sort of health field, like whether that was dentistry, physio, or medicine. And yeah, I chose physio. And the second part of this was that in high school, and I've given this sort of presentation to like first year physio students and human kinetics students, and I tell the story about how I knew of this young 17-year-old who was involved in a motor vehicle accident, and I had seen her go through this rehabilitative process, and eventually she restored her function, was able to get back to her daily life. And then at the end, I show the slide that I show a big family picture, and that person was my wife.
Wow.
My wife and I have been together for like over 30 years since high school. And so she was involved in a motor vehicle accident as a teenager. And so I saw her through her rehabilitative process.
And was she quite injured?
Yeah, this was a big car accident with a significant whiplash and fairly debilitating to start. And, pretty gut-wrenching as a university student who had to stop school for a little bit, right? And so I saw her through that process. I saw what those practitioners were able to do to help her restore function, and I was amazed by it. So I felt like that was something that I wanted to do.
You were curious to kind of learn more
For sure.
and pursue it. Yeah.
And then sort of part 3 is I also was involved in a motor vehicle accident later. So then I got to experience it myself. And I was just, again, fascinated by what you could do as a practitioner by just like asking people questions and understanding how this came to be, and then assessing it, and then doing all these things to influence your healing and recovery. Yeah.
I when just kind of like preparing for this conversation, I was reflecting on my own sort of journey over the years. I'm, let's say, middle-aged, and I've had the opportunity to have physio with a couple of different practitioners over the years. And it's interesting, like I wouldn't consider myself an athlete. I've always been physically active, but I was thinking about how pervasive, like chronic issues that we have, maybe even if we just have an injury as a kid, or like you said, like you're in a car accident, maybe when you're as a teenager or a young adult, and then how that can manifest in the body if it's not rehabilitated properly and come back to basically bite you in the butt decades later. Which is why I was like so excited to have you, because I think all of us have our own relationship with pain and our bodies, and how do we deal with that, right? A lot of it is like what coping mechanisms are we using, and are those healthy? So I'm super excited. I have like the longest list of questions for you that I know we're not going to get to, but I'm going to start kind of like at the beginning. Who do you think will get the most value out of this episode?
Yeah, I feel everyone from the general public to even practitioners who we often work with and collaborate with.
You like mean other healthcare?
Yeah, other healthcare practitioners. Yeah, because I think there is still, everyone has their role in primary care, and it's sometimes when one thing works for a certain condition, they will just stick to that, and I think later on when we get into like how health has changed, I think there's a lot to be said that there's a progression of much more collaboration and interdisciplinary care. So yeah, basically everybody, and everyone who moves and breathes and has the capacity to, if they're active and even if they're sedentary. So those are the people that we see on both spectrums.
Right. Yeah, I would totally agree. So I want to start by talking about pain, because it's usually the reason that people start to open up a conversation around what's happening in my body and how can I fix it. And like you said, I do think primary care providers are starting to really embrace the role that like practitioners like yourself, physiotherapists, can play in helping people deal with pain. So I'm hoping that you can because there's different kinds of pain, right? And I'm hoping you can kind of unpack what the difference is between acute pain, chronic pain, and mechanical pain, and like what that might mean in terms of finding a solution. So let's start with acute.
Yeah. First off, I think you hit the nail on the head when you mentioned people's relationship with pain. And if I can reframe it, acute versus chronic, acute pain is basically something fresh that's happened, right? Some tissue injury or insult that has happened that has created inflammation somewhere, and the body is responding to a potential threat. Chronic, or we've sort of gotten out of that vernacular And just because we don't want it for the patient to be seen as catastrophic, we kind of reframe it as more persistent or long-standing pain.
Okay.
Now.
Yeah.
So that obviously is a pain state or an experience that has lasted theoretically over 3 months. It's not going through the typical
Where you would be experiencing some level
Correct.
of pain every day.
Correct.
Yeah. Okay.
And it's theoretically not going through the usual healing process as it should. And then it's just now become long-standing, and everyone's pain experience is different, right? And that's what pain is. It's an experience that is individual, and the pain states now could be inflammatory or mechanical.
Okay.
So by definition, mechanical is a pain state. If I give you features of it, generally, someone wakes up in the morning, they're stiff and sore, maybe less than 30 minutes, but they get up and with movement, they're better. And throughout the day, with say stretching or active loading or strengthening, they're generally better, but then it'll kind of resume its usual pain state.
Right. Like where you sit down for a bit and then it stiffens up.
Yeah. But generally pain at rest isn't a thing. They're able to still work it out. And then from the mechanical state, conversely, it's lasting for, say, more than 30 minutes. It's lingering more throughout the day. Sometimes movement will increase the symptoms. There could be something visible like actual swelling or redness or palpable heat. Those can definitely be more amenable to like analgesic medications and things like that. And if you were to ask, someone on a numeric pain scale where they're feeling, sometimes that could be anywhere from a moderate to severe report.
Oh boy, it's so many questions. Okay, so you talked about pain at rest. Is that for me? That's always a bit of a red flag. So why are we concerned about pain at rest?
Well, I think in general, people will perceive pain as a threat or that something is being harmed. And that's not always the case. It's our brain and our nervous system reacting to something that's new. So the best way to respond is kind of give you pain so that the body shuts itself down so that you don't do that anymore.
Right.
But pain at rest could generally be just a sign that the tissues are still inflamed. So you can actually theoretically have both mechanical and inflammatory pain happening at the same time with features of both. It's just understanding whether or not your pain at rest is going to harm you. But I agree, like you have pain at rest, you're just sitting there and all of a sudden there's a little bit of an ache. Like, did I do something wrong? In general, especially if you're static, it's just the body's opportunity to tighten up. And then, which is why, as a physio, we promote movement.
Right.
You gotta move. And if that movement makes it feel better, then generally you're in a safe place with your body. If it makes it feel worse or increases over time as you continue to move, then there's likely to be more of that inflammatory process going on.
Okay, and then you also talked about a numeric pain scale, which is something I have 2 children, both are athletes, and this is what we use in our house to determine whether it's push through the pain kind of number on the pain scale or it's like cease and desist. So is this a good tool for people to really kind of understand and categorize or start thinking about their pain?
For sure.
Yeah.
And again, I mentioned that pain is individual. So what my 5 out of 10 is someone else's, 7, 8 out of 10.
Exactly. Yeah.
But it definitely is important as a practitioner anyways to understand what you feel, where you feel you're at, just so that can be sort of our baseline. And then as we go through the rehab process or treatment or whatever, see where you're at after a specific period of time,
right,
to see if that same activity is still creating that same numeric pain value.
So if there's somebody listening to this right now that's sort of just coming to the conversation and they're like trying to sort of categorize or compartmentalize their pain in relation to this conversation, would you recommend like anybody that's sort of dealing with pain start to check that every day and just be like, oh, today my pain's a 2, it's a 4, it's a 6. Is that a good practice?
In theory, yes. I would just be cautious that when, as you say, pain is a relationship. It can be someone's identity. So when you get into those long-standing, persistent pain states, sometimes it just becomes part of you and you're thinking about it all the time. And so that can sometimes create an overflow of a negative effect, but yeah, kind of like a negative effect that can enhance or amplify things later. But it is good to check in, especially through the rehab process, where you go from like an acute injury, like an ankle sprain, what's my pain level at week 1, day 10, day 21.
Mm-hmm.
Those are good measures for both the physio and the patient.
To determine how well it's healing and
right.
what have you. Yeah. It's very, very interesting. Because as you said, we are all sort of in different relationships to our pain.
Yeah.
My son is like weirdly superhuman. Like he doesn't feel things to the same degree, that my daughter does. Like I'm like, wow. So that injury looks pretty scary. He's like, what are you talking about? Didn't even notice. So I do think it's really interesting though, what you were saying about the emotional relationship that we have with our pain. And we can kind of get more into that. But I think it's also a really good place to frame the conversation because for some of us, sort of pushing through the pain is what we've been conditioned to do. Yeah. And for others, sort of like, I don't want to say the word victim, but like almost like ruminating on the pain is sort of could also be part of that conditioning as well.
Yes.
Right?
Yep.
And both of those can affect your overall outcomes. So
yes.
That's why I like the pain scale, because I'll say I'm retired. I might come out of retirement, but I used to teach yoga. And one of the things that I found is that a lot of people actually really don't know, like have a relationship with their pain signals in the body. Right.
Mm-hmm. And
so that even just consciously like giving it a number might be a great way to start to build that awareness.
For sure.
Yeah.
If it helps you understand where you're at and what your capacity is.
Yeah.
For sure.
Yeah. Okay. So, and I'm assuming that like you've sort of touched on it a little bit, but each of these different pain states manifests a little differently. Like acute pain would be like throbbing, burning, like, whereas chronic would be sort of like a deeper achy.
For sure.
Yeah.
Pain features can sometimes reflect on what tissues are involved.
Okay.
But yeah, you hit it acute, especially when the injury is fresh. Could be very severe. Could be very irritable. Like anything to like light touch with the sheets on your foot can like create that sort of acuity. Versus chronic, dull, achy. And then there's like nerve pain states too, right? Which can be lightning type.
Zingy.
Burning, zinging.
Yeah.
For
like
sure.
Weird.
Yeah.
I just had that. It's just such a weird sensation. I don't like it.
It's not fun.
No. And for anybody that is listening that is suffering with pain, just sending a lot of empathy and compassion, because especially it's that nerve pain, it can be debilitating. So This is why we have Vince on today. We're going to talk about this stuff. So you've said before that people often come to physio perhaps later than they should on their pain journey. Can you speak a little bit to that?
I think it reflects an understanding of people's capacity to manage pain. So most of those people either late in the game or after a persistent state of symptoms or after a long-standing duration of time after an injury, they've either just tried to self-manage and it's not bad enough for them to like miss work or stop their activity. They're just pushing through. But in those states, when things are left, say, untreated or not rehabilitated properly, you know, that can lead to other secondary things and compensatory mechanisms that by the time we see those people,
you're having to undo a lot more.
There's a lot to undo. There's a lot to fix, quotation marks. And so the prevention is where we want to get to, right? I see a lot of people for maintenance kind of things as well, or tune-ups, as they say. But we definitely want to empower that person to self-manage and catch it before, you know, it's too late. There are some people too that have kind of been around the system where they've tried, say, every practitioner possible, right? And in the case of TMJ, which we'll probably get into, that's what I find as well, because I think generally speaking, a lot of people don't know that physiotherapists manage TMJ disorders.
Okay, I want to go there because like I actually think I have it, but I don't have a diagnosis, but I like read a lot of Google, which I don't recommend as being a host of the Wealthy podcast. Google's not your best source for health information. This podcast is. However, I want to talk to you about TMJ because, or how do you say it? Temporal mandibular. I'm going to mess it up.
Close. Temporomandibular joint.
Okay.
Yeah.
I was close. Okay. So this is an area of specialty for you, and it is much more common than people think. I did a little bit of research and estimated 10 to 15% adults experience TMJ disorders. I think that's higher than this number because a lot of people like myself may just not know what they're experiencing is TMJ. So it's underreported. But also women between the ages of 20 and 40 are disproportionately affected. Interesting. Maybe because we're like always grinding our teeth. I don't know if that translated on audio, but definitely on video, you're feeling me. So for people who've heard the term TMJ but aren't quite sure what we're talking about, can you explain what it is, what this joint is, and what happens when it becomes dysfunctional?
Yeah, so TMJ is, as we know now, is the acronym for temporomandibular joint. And to accurately capture the dysfunction, we add a dysfunction at the end, so it becomes TMJ disorder or TMD. But I feel that it's an umbrella term to mean multiple things, and then we just categorize it after. But the TMJ is basically a ball and socket joint, right? It's
in your jaw.
In your jaw, you've got two of them. It's surrounded by a network of tissue, and it's a joint like any other in the body that like hinges and swings. In between the joint, there's a tiny little disc or tiny little piece of cartilage called the disc.
Okay.
And that's what can create a lot of trouble, especially with people who have like joint noises and clicking and locking. So these are tiny joints that you have two of that are joints like anywhere else susceptible to stress and strain. And because we have muscles that surround them, can also create aggravation and inflammation and just a world of symptoms.
And we use them all the time.
All the time.
Like
all the time.
Chewing and yawning and
But it has such a huge relationship with teeth, like dentition, but also because it's controlled by the higher centers of the nervous system can also be involved, you know, with the neck. So postural disorders, neck pain, you know, headaches, those are all sort of potential influencers and features of these pesky joints.
Okay, so let me just get this straight. What is a normal, healthy TMJ? You know, like it's really close to your ear, so you can kind of hear what's going on in there, right? If it's healthy and normal, functioning normally, does it make no sound?
That's a good question. I mean, yeah, like your jaw joints are built in proximity to your ear canal. So noises that potentially occur there are amplified. So I always say to my patients too, like if your ear was built next to your knee, you'd probably hear noises too.
Right. Okay.
And not necessarily a sign of insult or injury or pathology. It's just things are going to make noise.
Yeah.
There's fluid squishing around, right? And as long as everything else is okay.
Episode, I'm going to be like, moving my jaw around.
Yeah, as long as everything else is okay and you're functioning normally, then we don't worry about it.
Okay.
Yeah.
So, my kids are always like low-key grossed out. That's what they say. Low-key grossed out.
Yeah.
Yeah.
Same.
When I chew because something knocks. I don't know what it is. I don't really hear it because all I can hear is the chewing. Mm-hmm. But they're like, ew, like that is not normal. Is that normal?
So other people, they hear it as well. Okay. I mean, it's not normal, but it's not necessarily like a sign of harm or major issue. Like I said, we don't tend to worry about the noise unless it's creating other issues like locking pain or massive dysfunctions. But it can be like
sometimes it locks
anxiety
too.
Creating and nerve-wracking to have that noise come out of your joint.
how do you know when you need to go and see Vince?
So yeah, pain, headache, noises,
like pain in your jaw. Like where does it go?
Good
how
question.
Does it feel?
Yeah, pain can be focal to the joint itself, or a good sign would be if it's starting to spread or radiate, or be associated with function.
Like when you say radiate, like it goes down your chin, and
so
in the side of your neck.
Yes.
Okay.
Yes, or into the into the temple, into the ear, behind the eye, forehead.
Okay.
Anywhere kind of within that cranial space and facial space could still be related to the jaw.
And how do you know necessarily? I'm just asking for a friend. How do you know if it's just like, oh, I chewed some really hard gum yesterday for too long? Or, sometimes when I pet my cat or my dog, I stick my bottom jaw. I'm just like, oh, you're just so cute. Like, I feel like it's not. Stop taking screenshots of me, Jason.
I bring cards.
Yeah, but I feel like I'm not alone in this. So how do you know if it's just like overuse, or if it's truly TMJ disorder?
Yeah. So there are multiple causes or influences that create this scenario. Either direct trauma, someone's dental structure, right, and statistically, I see a lot of like adolescents, teenagers into their like early 20s with certain types of jaw profiles that will kind of create this.
Right. Like what? Like overbite,
so
underbite?
Both.
Yeah. Okay.
Both overbite, underbite, cross bites. Sometimes like post-orthodontics or even pre-orthodontics. And then like sometimes for people later on in life who are like under tension, grinding habitual things with their jaw, like that definitely can create it. Those are more of the sort of the physical things.
Right. And it would manifest as more ongoing pain and headache, some of those other symptoms that you were talking about, but it would be like, what did you call it? Like long-standing? Mm-hmm. Right. Mm-hmm. And so typically, what are people doing? So I've talked to my dentist about this. Is that usually what people do when they're experiencing this?
Pretty common.
Yeah. I gotta talk to my dentist about that. Is that the right call?
I think if you weren't in the know, for sure, because like I said, it could still be related to the teeth, the occlusion, in which case, that dentist could start doing things restoratively with the teeth. I don't want to speak for them, but that's what I generally will see in terms of helping to, whether it's realign or improve and optimize the position of the jaw.
Yeah, right.
So yeah, I think it's a good call.
Okay. And so let's say somebody does have a TMJ disorder or dysfunction. Dentists can't necessarily address some of the issues because it's not maybe teeth related or structural. What do you do?
So I would deal with more of the mechanical realm of things.
Okay.
Because we have an understanding of how that jaw joint moves and how it's influenced by the muscles, as well as all of the other kind of exterior extraneous things like the neck.
Right.
And
so
then,
it could be coming from like misalignment in the neck.
For sure. So dysfunction there, postural dysfunction. Like for instance, if I'm in a computer like this and I'm, slouching.
Ooh, tech neck.
Right?
Yeah.
Tech neck.
Oh, we're going to talk about tech neck.
Right? So I'm a forward head posture that's going to create protrusion in my jaw. And then something as simple as kind of creating postural awareness will help to optimize the position there. Yeah. But there are some deeper mechanical things within the jaw itself that would require, say, hands-on manual therapy or other treatment interventions like machine modalities or IMS, like intramuscular needling, things like that.
Okay. So can you stretch? I'm not going to do it because it's not cute. But can you stretch it? Like, are there stretches you can do?
Yeah. So a majority of my practice when I see people, so long as the assessment correlates with what I find, is like manual therapy. So I'm hands-on, hands in with a glove.
Yeah. Okay. Thanks. For
yeah.
That. Yeah.
I use gloves now.
Okay. Yeah. After COVID.
And yeah, because people will often come in with like limited movement, either because they're locked or have been in sort of like this tightened, restricted
so they can't
state.
like fully.
Yeah, they can't fully open, or they've had an actual disc displacement that will create a misalignment of the disc and the bone.
Like in here, in the joint.
Yeah.
So they're like.
Yeah.
Wow.
So we look for patterns of that, but then we have to assess to confirm it. And then, what do you do with something this stiff? You stretch it out.
Right.
So
okay.
you got to get in there.
Yeah. Yeah. Well, I'll make an appointment. Jason thinks I should just make an appointment. I think it's super helpful. And I do think it's so common, and even just people having the awareness that a physio can help. And if you are experiencing, the jaw pain, the headaches, certainly the ones like you're talking about that are kind of clustered on one side, neck pain, that a physio can actually help with that, because I wouldn't have known that until I came across your website. Actually, yeah. Is tinnitus, ear ringing, also an indication that there's something going on in there?
For sure.
Yeah,
potentially, like ear fullness, tinnitus. I know that you had an ENT on the show.
We did. Yes, he was wonderful.
Yeah. Dr. Dotremont, very good supporter of my practice as well, and so we actually often collaborate with these people that have features of tinnitus, and I think you mentioned vertigo as well. Yeah,
dizziness, vertigo. Yeah. Okay, so all of that can be coming from disordered or dysfunctional
potentially, yes,
joint.
Yeah,
interesting. Okay, I think that's going to be so helpful for people, because I really do think more people struggle with this. Why? Do you have an answer for the women stat? Like, why are women more disproportionately represented?
I don't actually. And in terms of like looking at the latest research behind why that is, I haven't been able to figure it out. I know that, say, women going through pregnancy and the hormonal change can often increase those symptoms because the elasticity increases through time, right? So in those cases, I'll often see people with like all of a sudden, like sudden locked TMJs,
right?
Or increased muscular pain, just because that everything is changing.
Of course, yeah. Right? And that may be enough to have an impact on the proportion of women versus men in that particular age category having more likely to have the dysfunction, TMJ dysfunctions. It's super interesting. Sorry, ladies, just another wonderful thing that we could get to deal with. I kind of want to talk now about, like, I think there's a common misperception or common perception that physiotherapists are for sports injuries. And I'll be the first to admit that kind of that's where I mean, I'm not a sport person, but like I would injure myself doing yoga or an activity, which sounds funny. You're not supposed to injure yourself doing yoga, but I did a lot of things that were probably shouldn't have done. But long story short, I think people have this idea that physiotherapists are just for injury related conditions, but they're not. And I want to talk about stress and neck pain and head and shoulder tension, like all of those things that maybe kind of are more lifestyle driven, that a physiotherapist is actually quite well equipped to deal with. So this one may be like more of that insidious pain that creeps in slowly from working at a desk where you're like sticking your head out, or maybe carrying a toddler, or just like life in general. I remember when my kids were little, pulling them in and out of that darn car seat was just like wreaked havoc on my book. This is all the fun stuff you have to look forward to, Jason. Wreaked havoc on like my body and my neck because it's just so awkward. So, and this is the kind of pain that people just like often live with. So tell me a little bit about how physio earlier, or as we're sort of moving through those phases of life, can be helpful, like almost more of a prevention lens.
For sure. Just to piggyback on your like car seat story, you wouldn't believe how many people come in with shoulder pain, just simply reaching like from the driver's seat into the back to like adjust the car seat or something like that. Or
to give the kid a fishy cracker, right?
Exactly.
Oh, I'm so happy my fishy cracker days are over.
But I think to speak to what physio is and how it differs first from other, say practitioner or allied health or rehab practitioners, we're primary care providers, and our scope, I can speak like hours on scope of practice and the breadth of what a physiotherapist is trained to do. But you hit the spectrum. Like we're there for acute injuries, persistent longstanding issues. We see people who have dealt with, sedentary related issues to dynamic sports. But basically, yes, we are there for prevention. We are there to help you through the normal tissue healing time frame that an injury goes through, and then we're there to help you with self-management. So the whole spectrum. And that's not just like musculoskeletal things, right? We see different populations within the hospital. We see neurological, pediatrics, pelvic health, like TMJ, right? So I think for the general population to understand is that we're movement specialists. We deal with pain. We can educate you. We are first line practitioners that you can come to be assessed, diagnosed, and treated. And if it's something, say, higher level medical that we can't address, then we can refer you on.
Okay, interesting. I did not know that.
Yeah. And then every province is different, and I'm speaking from an association lens now, but like it's interesting how within all of Canada, there are only 3 provinces that physiotherapists can order imaging or have the capability to order diagnostic imaging. And for big provinces like BC or Ontario or Saskatchewan, we can't do that yet.
Oh, okay.
But yet PEI and Nova Scotia and Alberta can, which is great. That's a big win because obviously we're in the business of helping people, and we want to have access.
Also takes some of the burden off of the health system.
Absolutely.
Yeah. And
that's what we want to do, is to make sure that people have access to it, burden, cost.
Right.
So
but at this stage, you cannot order diagnostic imaging.
Not in British Columbia.
No. But you can send a referral?
We So no, that's within the same realm.
Got it.
And I think the way that the process is anyways, we just have people go back to their family
doctor.
physicians.
Yeah. I have to say my family doctor and my physiotherapist work kind of hand in glove, which is really wonderful.
That's awesome.
Because as you said, like, it's not quite turnkey yet. But I do think, especially now with telehealth too, right? Like, it's not as cumbersome to go back to your family doctor and get that requisition for whatever kind of scan you need, a CT scan or whatever it is. We won't talk about the wait times on the other side, but we're trying, we're fundraising. Yay. MRIs. We got another one just last night, revealed that.
Amazing.
So I mean, I think it is good to know though that a physiotherapist can be a first line, rather than kind of like second or third or fourth or just not at all. Yeah.
And you may not know this, but like advanced physiotherapy practitioners is sort of a thing that's starting to be developed. So we have physiotherapists in the emergency room, right? And just so that's and primary care centers here in Kelowna and across the country. So I think people just need to start recognizing that a little bit more, that we're out there, and that we're, you don't always have to endure the wait time to see your family practitioner or nurse practitioner.
Well, and I think family doctors would be the first to say that some of those things are just outside the scope of their practice, right? And it's really great to see or to have experienced that, at least in my case, my family doctor is saying like, oh, see a physio for that. Go see a physio for that because they can help. And I do know that there are some clinics, I think the one in Rutland, the Rutland Community Clinic, do have in-house physio. And I'm really hoping as our health system evolves that there's more of that integrated care where you have primary care, like physicians, family doctors, but then physiotherapists, maybe massage, kind of all in the same area. Yeah. This is the dream. Let's build it together.
Multidisciplinary care for like, and not everyone comes with something simple, right?
Yeah,
it's multidisciplinary, multifaceted. So
and just being able to have like a care team, as opposed to just one provider. So I want to talk a little bit about, you mentioned like posture. Oh, I didn't ask you about tech neck. I actually feel like this is a public service announcement.
So
what is tech neck?
Tech neck, text thumb, and
text thumb.
Like wait for it. This is the new one that I've heard. Pickleball elbow. Yeah.
Pickleball elbow.
It's no longer tennis elbow.
It's pickleball elbow. Okay.
So all
is
all of these,
neck?
I feel that these are like Gen
those.
Z terms, like the
Gen Z terms for
recycled for what
Gen Xers,
right? Exactly. And it's basically this sort of like caterpillar position that you assume.
This is tech neck,
right? Tech neck.
Oh, so you're like your neck goes down. And
it's just a reflection of, I think, sign of the times and in what we're using for devices and technology, right? Computer, phones, and we're there all the time. Do you
raise your shoulders too? I always find I'm like, and my shoulders are up by my ears.
That's it. It's a postural dysfunction that would allow you that is enabling you to round your shoulders, poke your chin forward, and then in some cases, hike them up. And then you're just kind of under this state of tension and you're working through the day and you got to get this work done. So you're not giving yourself a break.
Right.
And that's a repetitive strain because you're creating undue stress. And over time, if your body doesn't have the capacity to adapt to that, well, in fact, it is adapting to that.
Right. That's the problem.
And that's the problem.
What do you do to break the cycle of the tech neck?
Yeah. So number one, if it is a workstation that is enabling you to do that, then a good ergonomic assessment or evaluation. And then an assessment of your posture. So looking at the mechanics, picking out any, say, muscular deficiencies or imbalances. But number one intervention would be for you to create an awareness that that's happening. And then take micro breaks during the day, like
right. Or
sit,
like
sit, stand.
sitting up a different, like being more aware of your,
And that's it. I think both. Being aware of your posture doesn't mean that you have to be like stick straight, because not everyone is optimally supposed to be there. That's, for me, I find that that's abnormal.
Yeah.
So just find what's neutral for you. But the key thing is just creating variation in your positions through the day.
Right.
And taking more frequent micro breaks. And if you have an opportunity to do so during the day, then stretch it out. Like take 2 minutes and stretch it out and return.
Okay. So you mentioned stretching and the, what is it? Text thumb.
thumb.
Okay. So apparently I am a bit of an anomaly also, in the sense that I only text with one hand. Like my kids do two hands, like, you know, but is this weird? I only text with one hand.
And is it thumb or is it like pinky or middle finger?
You're making me think about it. It's thumb. It's thumb. It's thumb. And not that long ago, my whole thumb just shut down.
Text thumb.
Jason's skeptical.
So repetitive strain, right? Like you're doing that multiple times a day for an accumulation of hours through the week.
Right. Yeah.
And
so is the fix to text with both thumbs?
Well, I suppose you want to create a balance of sorts to minimize the stress on that one part of the body that's getting really amplified in terms of its use.
Right.
So if you're going to text anyways, this is not heavily researched, but like text with, create a balance. Text with two thumbs, voice to text.
Yes,
that's a thing too.
Yes.
Or even like if you're used to doing the swipe.
Yeah, I got fat fingers. You know how, okay, so I'm wondering, maybe you can, so is this a test to see if you have text thumb? Is that stretch where you were just talking about stretching?
Mm-hmm.
I've just noticed when I'm like quadruped, like on all fours, and I turn my fingers towards my body and I stretch back, it's like, oh.
Do you feel a pain or just
no,
feel
I
like
feel
a
stretch.
alleviating stretch?
Is that like because I have text thumb?
It's possible that things have become short in that position. Yeah. And so you feeling or perceiving a good like stretch, if it feels good, then it's likely that it's become short or shortened, or those structures over time. So that would theoretically be a good thing to do.
Oh my gosh. Okay.
You don't have pickleball elbow?
Not yet. Okay. Tell me about pickleball elbow.
This is just honestly something new. I feel like
it's very relevant to our audience.
It's just something new that I've heard, and I actually don't play pickleball. I'm one of the very few. But I just look at it as akin to like tennis elbow. Tennis elbow. So just a repetitive thing.
Right. And how does that manifest? Like what would people feel?
Generally, it could be pain on the outside or the inside of the elbow.
All right.
That's aggravated by that activity, or sometimes aggravated by like simple gripping or taking a milk jug out of the fridge, things like that.
Right. Okay. Well, I'm amazed at how many people are. My husband is a like total rabid racket sports guy, like loves it all. And there's pickleball like everywhere. And we just opened up there's like the new courts on, I can't even remember. Is it D Hart?
Yes.
Yes. Yeah, and they're always full.
Yes.
So, I mean, I think people should know, like, watch out. You watch out for the pickleball elbow.
Should spread our cards there too.
You should for sure. But it's great that people are getting out and moving their bodies. It's like really 100%. Awesome. I want to talk about aging a little bit because it's also something we all do. And how the body shifts and changes and compensates over time, because I also think this is a conversation that needs to be had, that, you know, you're going to feel different in your 50s, 40s, 50s and beyond. And much of it or some of it could have a lot to do with things that happened decades earlier.
Right.
So tell me how the body compensates after a surgery or an injury. How does the body compensate over time, and how can these lead to these chronic issues? Like, I just have a bad right hip. No one thing can point to it. It's just cranky. Yeah. So can you explain how that happens?
So again, it's just understanding what your pain state is like. But I feel that you can't undo what has been done in the past, and you can't change the natural course of like aging and structure that would potentially create like arthritic states and changes in the joints and things like that.
Yeah, like, so for example, like in my case, I'm always sort of, my story is like, I was a gymnast as a kid. I've had 2 babies. I did advanced yoga posture for 20 years. And all of that has now shown up as, for lack of a better term, my cranky right hip.
Yeah.
So are there things, even if these, cranky aches and pains, it's not just, I mean, it is aging joints, but are there things that we can be doing?
For sure. And the body is resilient, right? It's meant to heal. And as long as you feel safe in moving, and because motion is lotion, right?
Yeah.
Then that's what generally people should do. We're exercise specialists, so we're forever promoting exercise and good health, and that exercise could also include rehabilitative type exercises as well. And again, going back to like pain awareness and understanding the nature, and to make sure that they feel safe in progressing with whatever they do. But if it's just, say, like an ongoing hip thing, obviously seek out some professional care to address why it's still there, because maybe it hasn't been addressed right at all. And so understanding the potential influences, and maybe there's a pathology there, maybe there is arthritis that has been left like undiagnosed that we can manage and treat. But I would say, as long as daily life is carrying on, you're able to push through it, then it's unlikely that you're creating more of a harm to your tissues.
Just to keep going. So, and one of the things I've learned over the years is that sometimes where the pain isn't necessarily where the problem, like the origin is. Right. So, for example, I'm going to mess this up a little bit, but that's okay because you're a physio, so you can correct me. But like, if you have pain in your hip, it could be because of a misalignment in your knee that hasn't been treated. Or if you have pain in your knee, it could be because of a misalignment or some issue that you have in your ankle, your foot, that hasn't been properly addressed. So that's where having a professional to kind of come in and look at like what is actually going on. You might be treating your hip, like stretching and doing all these horrible, like the frog pose and this, oh man.
Yeah.
Listen, I love a frog, but but it might not necessarily be the hip that's the issue. True. Or does it go the other way?
No, you're right. Where you have pain is not necessarily the source. And so that's for a physio to determine or help you understand. And then speaking to that, not all pain is mechanical or tissue or neurological. We can get into these long-standing persistent states that's called nociplastic pain states, right? Where your body's perceiving pain or giving you pain, but there's not necessarily a tissue threat. And that can be a whole that can be a whole nother discussion. But
so like there's no inflammation or
Correct. Oh. And that probably speaks to more in the realm of the stress and someone's mental health capacity and well-being at that time.
Okay, I'm going to double click on that.
Yeah.
Is that pain real pain, or is that like perceived pain?
Well, that's a good question. It's definitely real pain, real perceived pain for that person.
Right. Okay.
And so that is the challenge of any healthcare practitioner is to understand what that real source is.
Right.
And thankfully, there's like a world of like pain science research out there now that we can kind of draw information from. But the bottom line is that, you know, for your patient, it gets down to like safety. If they feel safe with the symptoms that they feel, and knowing that they can adapt to daily life and activity without the sense of like that they're harming themselves or they're harming or continuing to damage their tissue. It's our job to change the message and the framework and the mindset for our patients and enable them to do that so they can carry on with confidence.
Yeah.
Yeah.
And I don't mean to kind of like harp on it, but there was that old adage in training, like no pain, no gain. Is there a difference between like, you know, if you're training, I mean, I sort of understand enough about training that there is some, I don't want to call it pain because like, but it is, I guess, discomfort involved. But when do you know when to push through that, and when do you know when to pull back?
Yeah, it's sort of the old hurt versus harm concept, right? And again, it's just understanding what features you have after you've pushed yourself. If you recover from it, and going back to that pain scale, I often tell patients if you're within a 5 out of 10 capacity and it goes away when you're done, then that's probably just a little hurt, like a workout soreness. You haven't damaged anything, especially if you can continue to carry on with life.
But if it's more than a 5,
then you've done something. More than likely.
I need to send this to my son in Toronto, who's, like we talk about the relationship with pain, right? And especially for athletes, I think there's a bit of a gray area
for sure
there.
And how that can affect the psychology of it as well in dealing with that.
Yeah, totally. Yeah. And it's true. You're right. And we didn't really touch on that, but there's a big psychological and emotional component to all of this.
Every person has a biology, a psychology, and a sociology, right? So physical, the brain, the nervous system, and then environment. And all those 3 things influence a person's pain.
Right.
And that's for us to help understand and help the patient to navigate around as they go through whatever rehabilitative process that we see.
I'm going to ask a question. And if you don't have the answer, it's totally okay. Sure. I'm just curious. You talk about sort of like the psychosocial kind of environmental factors, right? And so like, let's say you are a high level athlete and you're in pain, but the pain of not participating would be more than the pain of pushing through the actual physical pain.
Huge.
What advice, or like in your case, like if you treat athletes, do you help them then navigate that physical acute pain so that they can get through and do the thing?
Yeah.
I know it's like an ethical thing too, right? But like, I imagine that's a thing that comes up quite a bit.
We're faced with this all the time. And, you know, and we deal with pressure from coaches and parents, right? And so, but the biggest thing, the main thing is that we have to come at it with objectivity. So like if your ligament is torn, I can't send you back. Like you have to sit. And if you are
right, because you're going to like do more damage.
Yeah, exactly.
Yeah.
And so you're right. Like there's an ethical like responsibility that we have, partly medical legally as well. And, you know, I don't want to take the risk in sending someone in just because they told me they feel okay to go in. But if the objective signs are there that, you know, you're probably going to rip this more, or you're going to take it to the point where you actually fracture a bone or something. Like I have to be upfront and tell you that
these are the risks.
Yeah.
I can't. Yeah. What if it's something less, like a torn ligament is kind of like, you know, it's a torn ligament.
Tape it up and go.
Yeah. Like what if exactly. Like what if it's less cut and dry and it's, you know, a rolled ankle or a sprained ankle or a sore back or a, you know, I don't know.
And that's the education piece. So it's like, okay, yeah, sure, you can go return to work because, like, I understand you have financial responsibilities, or, you know, this is your one shot at provincials. I understand. And so telling people, here are the facts, this is your risk, and if you choose to do it, that this is what potentially
proceed
will
at your
happen.
own risk.
And that's basically it.
Yeah.
But my obligation is to make sure that in the end, like, you're not going to damage yourself further, and
More
that we
harm.
we can carry on.
It's so hard, hey?
It is.
Yeah.
Yeah. The interesting thing too with the stress component is relating to TMJ. It was an interesting thing coming out of the pandemic when we returned to work. How many people, especially students, who were isolated after a period of time ended up with just this insidious, like, non-specific onset of jaw disorder and then facial pain and headache. And they had no issues prior to. I wish I'd done a study, because, like, every person, every teenager, every, like, 20-something, and then even middle-aged people who felt that they were isolated after a period of time, like, just all of a sudden came to me with, like, jaw problems and headache and facial pain and neck pain. And not, like, I'm pretty sure that the stress level and the environment and the psychology, the psychosocial aspect of it all, like, really influenced.
Had a dramatic impact.
Huge impact.
Yeah. And so I guess then it would also be like for folks that are in transition, right? So I've got a kid going off to university, right? Being mindful of that these are the times that we're vulnerable, you know, life transition, a parent passing, or, you know, those times of life where there is more maybe acute stress, that you're more vulnerable to these types of disorders or conditions.
I would say, like, not even anecdotally, but yeah, from a scientific perspective, yes.
Interesting. Yeah. Okay, I'm getting the nod that we're almost done. I would like to switch gears a little bit, because I kind of want your perspective on sort of the big picture. You've been practicing for a number of years.
Yep. 24.
Yeah. So how would you say, you know, from young Vince in university to today, how has your definition of health, or what constitutes healthcare, changed?
Yeah, it's a good question. I alluded to it earlier. Just it's been nice to see the shift from kind of siloed practice to now, you know, people are willing to collaborate and move into multidisciplinary clinics and primary care centers. I definitely have seen the evolution of, like, treatment strategies from, you know, bed rest, don't use it, tape it up, like, ice it and leave it for 6 weeks, to an active approach. Because, as I said, bodies are resilient, and people just need to understand that, you know, it's okay. It's going to be okay. And,
but that's, like, actually really has changed, because back in the day, it was like, if you injured yourself or you had surgery or, you know, you weren't feeling well, even the prevailing recommendation pretty much for all things was rest. But now it's not. It's move.
It's move.
Yeah.
Yeah. Motion is lotion. And like, movement is so good for the body. And again, as long as you understand what your pain state is like, then you're pretty well safe to do anything. And that's definitely what I've seen in the rehab space anyways, is strengthen at any age. Strengthen your 90-year-olds. Get them to deadlift 135 pounds, you know? Like,
goodness.
Heck yeah. Yeah. Seriously. I was just on a orthopedic symposium last week that was hosted here in Kelowna, that I was part of the planning committee. And one of our presenters, you know, presented on the fact that a lot of our senior population live with this sort of 1 rep or live beyond kind of the 1 rep mentality. Like, and so if that's the case, and they need to pick up groceries from the floor to their counter, why are we training them to just do this like one time when they live, or getting them to do sort of static, meaningless exercises?
Yeah.
Right?
Yeah.
Versus get them to pick up heavy things off the floor.
Farmer carries.
Yeah.
Yeah.
Seriously.
I know. I also think that is like been a huge light bulb for me, is just those farmer carries. Like, so for anybody listening that doesn't know what a farmer carry is, Vince,
I do.
Do you want to explain what it is?
Well, it's basically you're carrying heavy weight on both sides and walking a certain distance while carrying it, and trying to keep your core braced and balanced.
Yeah. Because there's a direct correlation between like grip strength, which is what you're using when you're doing your farmer carry, and longevity, right? And maintaining muscle mass as we age now, we're learning, is absolutely vital. So even just like the farmer carry, pick up heavy things and walk with it like a couple of times a week is supposedly like really, really good prevention and medicine.
And speaking of like prevention, like fall prevention, we teach like some of our elderly populations to do a burpee, because I've dropped something underneath my dining room table. I'm not just going to squat over or bend forward.
Oh yeah.
I'm going to get up off the floor, get down onto the floor in a push-up position, reach for it, and then get myself back up, because sometimes if I fall, I need to know how to get up.
Oh
too.
yeah, and falls can absolutely be devastating for people. So I think that's really, I mean, does anybody really love a burpee? I don't know, but there's very good reasons to do. I just did burpees the other day for the first time in a little while, and they're humbling. You are required to use all of your body parts. Yeah,
but it's a great multi-use exercise.
For sure. Yeah. Awesome. All right. All of our friends out there are going to do some farmer carries and
please do
burpees. What's your other favorite go-to recommended kind of exercise?
Squats are, again, they're multi-joint exercises. We squat when we sit. Yeah. We need to stand after we sit. So just those basic things are functional, like good functional tools in life. Okay.
There you go. There you have it. The regimen from Vince. Squat. Oh, we'll throw in the deadlift there, but be careful, because sometimes it's hard on the lower back. Farmer walks and a couple of burpees in between. Fun. So fun. Okay. So I we're very proud of how clever we've been with our podcast name. It is the Wealthy Podcast. Healthy, meaning that health is wealth, and also recognizing that health is, as you've said, multifaceted. It includes more than just sort of our physical health. It's emotional, social, cultural, community. In what areas of your life do you feel you're wealthy?
Cool. Well, my family life, for sure. This community has embraced me for the last 10 years, and I've gotten to know a lot of really, really good people who are also communitarians themselves. And just the ability to get to know this community locally, but also as the president of the provincial association, get to know the actual like province. So I feel that from a networking perspective, I feel very fulfilled. Those who know me know that I've been a professional volunteer for over like 20 years, serving as presidents of different associations and so on. So my sort of the network and the friendships that I've developed over that time across Canada, I feel very fulfilled as well.
Why do you feel it's important for you to be participating and volunteering your time in that way?
I mentor a lot, and when people ask me why I still do this, like the the non-paid stuff.
Yeah.
Right. I just feel that physiotherapy is more than just like clinical work. Yes, I love getting to know the stories of people, but just getting to learn about the profession in that different capacity, and to have an influence on, advocacy for the profession. Not that I think about like what legacies, I'd like to leave, but just knowing that I had a hand in someone's development of this process and policy or what have you, is just, that's fulfilling for me. And, it's definitely admittedly served my career over this last 24 years. So, yeah.
Well, this has been awesome. And it's been such a pleasure to meet you. And thank you for sharing all of this information. It's interesting. We take for granted so many of the clinicians that are working out in community doing really, really amazing work. And you're one of them. And also thank you for your service on, the provincial board. It is, for us, we're the KGH Foundation. We recognize the contributions that volunteers make. All of this wouldn't be possible without the good work of people like you and others in the community that are willing to give their time and their experience to help advance, whatever area of specialty or interest it is. So thank you for that.
Oh, thank you.
And thank you for joining us this morning.
I appreciate this so much. Yeah. It's been awesome. Thank you.